But today I'm going to talk about sort of a summary of the work I've been doing with older adults in schizophrenia. And I've managed not quite to condense it into E equals MC squared, but I've tried to condense it into fairly short synopsis of the essence of what we've been doing for the last 2 decades in this area. And I wanted to also try to use it as a way to illustrate how one thinks about research in other areas as well, not just people with schizophrenia, but in medicine as well. So I want to talk about, first of all, the importance of why you might want to be interested in people with schizophrenia. Even though schizophrenia develops in young age, usually in second or third decade, we see more and more people with schizophrenia surviving into old age. And even though their mortality rates suggest that they often have 10 to 15 or even 20 years lower lifespan than the general population, the absolute numbers of people with schizophrenia in later life are increasing. Between 80 and 85% of people with schizophrenia develop the disorder before the age of 45. So most of the time it's early onset. And even at age 60, the prevalence in the population is about 0.35% early onset, 0.14% late onset. Those are people with an onset between 45 and 60, and 0.03% very late onset, those 60 and over, which is a kind of other category, excuse me, that we're not exactly sure if it even belongs under schizophrenia. We call it very late onset schizophrenia, but some people call very late onset like schizophrenia. But you can see the total prevalence of schizophrenia is about 0.5% in the population over 60, the general population, of which about 2/3 or so are roughly people who had early onset. And we expect the numbers to increase dramatically over the next few years. And indeed, in the first quarter of the century, there were roughly about 500,000 people with schizophrenia 55 and over. And this number now has gone up close to 750,000. And more importantly, about 1/4 of the persons with schizophrenia will be in this older age bracket. By 2060, and many of you still be practicing then, or maybe not, but perhaps, one half of the people with schizophrenia will be 55 and over. And globally, around the world, about of people 60 and over, the numbers will double pretty much over the first half of the century to about 10 million people around the world. Of those, again, people, older adults with schizophrenia. Most of the people now with schizophrenia are in the community. You can see about 85% are in community, about 10% in nursing homes, and 5% in hospitals. Used to be pretty much the other way around. Almost 85% were in psychiatric hospitals. If you look at the mid-20th century, the 1950s, there were huge numbers of people in psych hospitals. Well over 500,000 people at that time were in psych hospitals. So there was a deinstitutionalization movement and people began to be moved into community settings. And some were trans-institutionalized, as we say, into nursing homes, for example. Now, what I want to talk about today, again, is outcome in schizophrenia. This is a traditional view. It's and you still see these kinds of slides. And Jeff Lieberman, who did this slide, came to a grand rounds at Downstate not so long ago and put up this slide. So we still haven't penetrated that well, the new view of schizophrenia that I'm going to present today. But it's typically seen as something that develops early in life with a lot of ups and downs in midlife, And then in later life, especially when it gets into the 50s, it kind of stabilizes. It's quiescent, its thought. And this just is not true. And I'm going to show you that this view of schizophrenia is really needs to be revised. And indeed, we are revising it in the literature. So I want to make 6 points about outcome. And again, I think this pertains to outcome in a lot of disorders, not just people with schizophrenia, but other mental disorders as well as medical disorders. One is that outcome changes historically because evolving criteria of schizophrenia, criteria for outcome and social factors. And another point is that these studies often are cross-sectional, and we need to look at those that are more longitudinal. So as you can see from this slide, studies that were done in the early part of the 20th century, these are the ends over here, but the percentage of people improved were somewhere 20%, 30%. Suddenly, it markedly improved in the 60s and 70s and early 80s. And then it declined again to levels that looked like it was like we had gone back to the early 20th century. Now, is this a failure of psychiatry? Have we just accomplished nothing in a whole century, or what? And these were represented somewhat longitudinal studies. They were short term, but they were people who followed for a number of years. So that was the good news. What seemed to happen is that around the 1980s, the DSM-3 came into play, and it set much more stringent criteria for schizophrenia. So people who might be schizophreniform or something like schizophrenia were classified in the 60s and 70s as, in those categories, and tended to do better. So setting certain very strict criteria probably weighted it towards people who were more severely ill. Now, the outcome, as I said, changed dramatically during the 20th century. Kraepelin, who coined the term, called schizophrenia at the time dementia precox, or early dementia, found basically only 4% recovered, and 17% showed improvement. First, he thought no one recovered, but then later on decided that there were some people who did recover. Boiler, who coined the term schizophrenia, also felt that the prognosis was terrible, and it was people ultimately lost function. In DSM-3 in 1980, the most common course was one of acute exacerbations with a greasy impairment between episodes. So it was also viewed at that point as a downhill. Now, a series of articles came out in the 1970s and 1980s that showed people followed up for 20 or 30 years. Most of them were in their 50s, 60s, 70s even. And what you could see here is that the people who were considered recovered or significantly improved ranged quite high, from 49% or 46% to some studies, one study, 84%. And percent socially recovered also was about 50%. So this was a marked change in the thinking about schizophrenia. Now, these studies were done at one point in time. They took basically a snapshot of people who were seen, who were in the hospital 20, 30 years ago, and then re-interviewed 30 years later. Some cases they were followed over time, but in many cases they weren't seen very often. In the late stage, they were seen just once. Now, this is sort of how schizophrenia was viewed by the people who were doing these long-term studies. They said the point that was first clear was that schizophrenia is not a single path. People follow a heterogeneous course. There are people who show ups and downs, acute exacerbations, and they look pretty good in between episodes. There are some who show a kind of insidious course, chronic, and stay chronic most of their lives. There are some who show acute exacerbations and then become chronic. There are some who chronic who then become almost disappear. The symptoms disappear in later life. As there are some who start off kind of chronic, become acute, and then symptoms disappear. And then there are others who stay chronic, have an acute onset, but stay chronic after that. And then there are other kinds of patterns. And what you can see from this is about this pattern, the pattern 5 here and pattern 8. These showed favorable outcomes in their end stage when they assessed them in later life. And this equaled about 50% of the group. So approximately half of the people were doing pretty well. So that, again, the take-home points are from these studies are that schizophrenia has a much more heterogeneous course than we would think. And look at some of those graphs I showed you earlier where they kind of just take the average of what people look like. It's clearly not what it should be. And then even in later life, there's variation in terms of how people do. What they didn't know, and what I'm going to show you today, is that even in later life, there's much more activity going on with the disorder. So we see this kind of trend going on between first 3/4 or even more, 5/6 of the century, 20th century. The feeling was schizophrenia had a very poor outcome. Under 20% would recover or improve. Then for about 30 years, the feeling was about half the people are improving. And then more recently, in studies we've done and some others have now done, we found that it's about 25% because we followed individuals over time. And again, I want to emphasize that. The important thing is, well, group data, taking a mean for a group, is important information epidemiologically to understand how patients are really doing over time. You have to use longitudinal data. And when you follow people over time, some people switch back and forth between improved states and non-improved states. And only 25% showed persistent remission. So this is an important point. And again, you could think of this in the rest of medicine too. If we wanted to know something about hypertension, for example, taking a snapshot of the population, a cross-sectional study, you might find that 50% of the people had their hypertension controlled. Just using that randomly here. But if you followed individuals over time, you might find only 1/4 of them really stayed on the medication, antihypertensives, and really controlled it properly. So it's important to distinguish those things in medicine as well as in fields such as psychiatry and the study of schizophrenia. Any questions at this point? Anybody have anything? Okay, I'll move on. Point 2 is how you view outcome. And again, this is true in medicine as well as psychiatry. You want to include symptoms, but functionality, how people function, is very important. And even in a combination perhaps of symptoms and functionality, which we sometimes call recovery, and I'll get to that in a bit. But that's also important. And finally, positive mental health, or we now look in the rest of medicine, positive health. It's not just looking at deficits that people have, but strengths and resiliency that people have. What do they do to be above average and to do really well as they age? So we may want to look at that as well. Now, the common symptoms outcome are important in schizophrenia. If you look at the diagnosis of schizophrenia, it's based on having some psychotic symptoms such as delusions and hallucinations and impaired thinking, disorganized thinking and disorganized behavior, and what we call negative symptoms, apathy and lack of affect, for example. But there's more to schizophrenia than that. It's well known now that schizophrenia is accompanied often by depression, depending on criteria for depression. Somewhere between a quarter to 3/4 of patients with schizophrenia have depression. They also have cognitive impairment, sometimes mild, but sometimes more serious. And this often begins at the onset of disorder, but remains for the rest of the life. There's some cognitive dysfunction, though it doesn't usually progress more rapidly than with normal aging. So people will show some decline, but it's not rapid decline because of schizophrenia, though there's some debates about that. And perhaps there are subgroups that show a more rapid decline as they reach a later life. But we also want to look at functioning as well. If you recall the diagnostic manual, DSM-5, you really can't have a mental illness if you don't have impaired functioning. You can have some psychotic symptoms, as many in the community do, but if you're functioning pretty well, you're not considered to have a mental illness. So we want to look at whether people have community or social integration. I'll define that in a bit, but it's whether they're have an active social network, whether they're involved with community activities, whether the quality of life is good, things like that. We look at also just adaptive functioning, whether they can do their ADLs properly. And some people look separately at quality of life, subjective well-being, if you will. And again, this is all relevant to medicine. The World Health Organization emphasizes these are critical measures that we have to use in the rest of in all healthcare, the social functioning and quality of life measures. Sometimes we could combine these, and if you combine the clinical and the functional measures, we come up with a term called recovery, clinical recovery. There's another term called recovery, and we'll talk about in a bit, that's a little different, that's used in psychiatry as well. Finally, I'm not going to talk about much of this today, but positive aging, that to be successfully aging in a way based on having good health, social well-being, and psychological well-being. And very few people with schizophrenia attain that. So about 2%. But even among normal community elderly, perhaps only about 20% would meet this criteria. So many people feel, that probably double that number, feel they're aging pretty well. Now, just to tell you where my data came from, we had done a large study in New York City, about 249 people, 55 and over, with early onset schizophrenia spectrum disorder. So include schizophrenia as well as schizoaffective disorder. And about 2/5 of them were living independently in the community, and 62% were living in the community, but they were living in supported residences, which might have services there. Some of these support SR, single room occupancy hotels, where people would have a room and there would be agency staff there. Mean age of the population was 61. We excluded people who were severely cognitively impaired. About half were men, a little more than half were white. Out of the original sample, we were able to locate about 65%, some of whom were deceased, and others had moved to a nursing home or we couldn't interview. And because of some changes in some of the places they were living, they got displaced, and we were unable to locate most of them. So we were left with 104 people we were able to interview 52 months later. And there was a range in that. And there weren't much differences between the people who we couldn't interview in the original and the people we could interview, there was a slight difference in age. The follow-up group was very slightly younger than the people who dropped out, but minimally. It was about 1.5 years difference. So one of the things I want to point out is we have various outcome criteria that we use for schizophrenia and really comprise the dimensions of schizophrenia. And they're largely independent of each other. So let me unpack this slide for you. So I'm looking here at remission, which includes whether they're clinically in remission. I'm sorry, this is clinical remission, not recovery, I'm sorry. So they're in clinical remission, which means that they don't have positive or negative symptoms, or very minimal positive or negative symptoms. They may have some, but it's very minimal. And the DRS is a measure of cognition. Some of you attend our clinic, well, a lot of you do, but when we do the new patients, we often do the dementia rating scale. And we looked at them at 2 points in time, and the CSD, which is a measure of depression. And we also looked at a measure of community integration, which includes whether, they said, people have a reasonable social network, whether their quality of life is acceptable, whether they're attending churches or senior centers and other kinds of community activities. So what you can see from this is that, yes, there are correlations between these things. The highest one reaches about 0.47 between mood and community integration, which you might expect. But this still isn't overwhelmingly overlapping. The shared variance, which is a way of looking at how these variables overlap with each other. You know, if they were shared variance was 100%, they would be like one circle on top of another, sort of, if you will. But only about 1/5 of the variance is shared. So 80% is kind of free or not related to the other variables in any way. So these are independent outcome measures. And why is this important? Because it what you do to, let's say, affect remission, you know, the positive and negative symptoms may or may not have much impact on cognition or mood or community integration. A little bit perhaps, but not much. So we have to begin to think about approaching each of these things separately. And again, you could think of the rest of medicine, whether you have a person with an illness, certain symptoms you treat may get better with medicine, but you may have to do other kinds of physical therapy or other things to get some other aspects better. So we'll return to some of this later. Now, one of the things that I wanted to disabuse you of is the fact that the outcome is not quiescent or stable in later life, but continues to evolve. Again, this is the picture that has been painted and still existed and still does exist in some textbooks regarding schizophrenia. I might point out that part of the reason this was so is that people looking at older adults with schizophrenia is not well studied. If you look at the literature on schizophrenia, only 1% involves older adults with schizophrenia. So it's a kind of a dark area, an unstudied area of research. So there's tendency to, first of all, just to look at the single line, a mean value. I told you this is a problem to begin with because there are heterogeneous courses, and then not to look at people over time. So this is not a correct view. Now let me show you why. Again, I'm going to take some of these domains, these different outcome domains, and show you that how much fluctuation there is. So clinical remission, again, how much positive and negative symptoms one has. And if one has very minimal positive and negative symptoms, you're considered to be in clinical remission. Only 25% of the people were in clinical remission all the time. If you looked at them at one point in time 1 or time 2, Indeed, about half of them looked like they were in remission, but they were fluctuating in and out. 35% were never in clinical remission. Likewise, community integration. People, about 4/5 were never in community organization integration, as we measured it based on norms for the community comparison group, but 26%, a quarter of them, were always integrated. And again, there was a huge number, close to 40%, that were not, it fluctuated between the two groups. Now, if you looked at recovery, which is a measure of both remission and high community integration, you can see only 12% were always in recovery, 18% were never, and then there was a group that fluctuated. Really is about 70% that fluctuated. I'll show you some more about that in a minute. And again, cognition. We said cognition is impaired in schizophrenia, and there was about 25% that were always below the DRS level of 130, which we use as a cutoff for mild dementia. 43% were above it. But then there was another group, about a third of the people, who fluctuated. Some got better, some got worse. So even cognition can improve, often depending on other things. Somebody's level of depression or psychosis can have an impact. And what about depression? A huge number, about more than 2/5, were never not depressed. In other words, they were always depressed. And this was included subsyndromal depression. They didn't want a major depression, but they had clinical depressions. About 25%, a quarter of them fluctuated between states, and about 30% were always in pretty good mood. So the point here is you can see that there's a lot of movement that goes on in later life. It's not a stable quiescent state. And the good news is there's a chance to intervene and to make, get people better. This group over here, never, is maybe more difficult to move forward, but this group in between, representing a quarter to 2/5 of the population, may be a group that's ripe for interventions that can be very useful. Now, the next point, any questions at this point? Okay. Fifth point is outcome is heterogeneous with a variety of combinations and necessitate a personalized approach to care. We're getting that in medicine now too, that everybody's a little different. And we've been, I just finished doing a study reviewing a large database of people with Alzheimer's. And we know that they have different courses, and people, some people have a steady, rapid downhill course, but that's only less than a third of the people. There's another group that has a very slow course. There are people who about a third of the population is pretty stable, but some zigzag up and down. They can look like they're going down, and then they zigzag up, and then there are people who improve. So even in other disorders like dementia, we're learning that it's much more heterogeneous than we previously thought. Now, one of the things that's talked about with older people in general, and even more so with people with schizophrenia, is the notion of paradoxical aging. And people, please, somebody doesn't have their microphone muted, try to mute it. Now, paradoxical aging refers to when older people show a physical decline in cognition and physical health, but their quality of life, and they report an improved quality of life and psychosocial functioning. So, and this is true in older people in general. Many older people actually are happier than people in midlife or younger people. You would think there would be more problems because of having more physical issues and cognition getting somewhat worse, but they actually seem to be doing subjectively better as they age. And this is thought to be even more so with people with schizophrenia, that they show these declines, but they seem to report doing better in later life. Now, this paradoxical aging as a group norm may be true, but again, it's much more nuanced when you begin to look at heterogeneity. So as you can see from this slide, in our follow-up, if we looked at people who were worse over time or persistently worse, or who got worse over time as we followed them up, about 60% of people were worse or got worse when we followed them up. And about 40% were persistently favorable. That was about, as I mentioned, 25%, but another 16% got better over time. Same with community integration. There were people who stayed bad or got worse over time, but a total 45% either got better or stayed persistently well. Likewise, with depression, there was movement, 54%, 46%. Cognitive functioning, there were some who got worse, but remarkably, 57% stayed well or got even better over time. And we didn't have a measure, we didn't do a physical exam, but self-health, as people show in this group, 36% were persistently in poor or fair health or got that way over time, but 64% remained in excellent to good health or reported getting better over time. So you can see there's almost a dichotomy between people getting worse and unfavorable and those who are favorable and better over time. But this is a group norm. Now we look at individuals, different people have different patterns. So you see this, there are people who are good on all the 5 outcome measures, not that many, 5%, but there's a lot of people in the middle here who are good on 2, 3, or 4 of the outcome measures. They're either persistently well or getting better. And in a few who are only 1 or 2, maybe about 20% who have mostly unfavorable measures. So you can see that you need to sort out where the people are getting better, and it's a mixed bag, and there are all sorts of patterns you can have. Think of all the possibilities. What are the possibilities if you measure statistically is 5 times 4 times 3 times 2 times 1. So there's all those possible combinations you can have that somebody can have as in terms of outcome. The final point I want to make is that recovering recovery can be assessed empirically and yields a 5-tier taxonomy with varying degrees of recovery that provides guidance for treatment. So let me first say, sorry, I have allergies today. I'm a little hoarse. So in psychiatry, we have a notion of recovery that's a kind of a non-clinical, what I call non-clinical recovery. People use it in community psychiatry, especially where we say that people are in a movement. They're moving towards recovery. It comes from the drug treatment culture, where somebody is in drug recovery. They may never be fully recovered. They're moving. They're always in a process of recovery. Sometimes they they are off the drugs, but then they may have a relapse, but we still say they're in recovery, then they work back to recovering again. Now, I have a little bit different take on it. I feel to really know how somebody is doing, to get for treatment purposes and intervention purposes, we want to have a definition of what I call clinical recovery. So that means that, and I mentioned this earlier, somebody's in symptom remission, positive and negative symptoms are 3 or below on this on these criteria that was set up. So they have very mild positive and negative symptoms, and they're in functional remission. The community integration equals their age peers, and the community integration I've already mentioned measures a variety of items. We can look at them in 4 components: independence, going to places, shopping; psychological integration, where they feel satisfied with their neighborhood, with their residents, with their family support; physical integration, where they join activities, they have a good sense of self-esteem; and social integration, where they have several kin members, 3 or more, or network members, and they attend church or senior centers, things like that. So if we look at clinical recovery, and we look at it over time, if we take the snapshot view, cross-sectionally, almost half of the people are in clinical remission, as I mentioned before, but only 25% over time are in clinical remission. They're in persistent clinical remission. Now, with social integration, community integration, you take a first snapshot, about 37% are in community integration, but when you follow them over time, only 26% are in persistent community integration. Now, to get clinical recovery, you have to have both community integration and clinical remission. So to be in both of those, cross-sectionally, about almost a quarter of them are in clinical recovery. But when you measure them longitudinally, who stays in clinical recovery over time, only about 1/8 of them remain that way. About half of them only remain persistently in clinical recovery. As I mentioned before, positive health or well-being, successful aging, is only about 2%, very rare. So how does this stack up with other studies? There was a study done, our cross-sectional rate of 22% was higher than a cross-sectional rate reported in a study in San Diego, which found 8%. The catamnestic studies, those studies I showed you in the beginning, with hospitalized patients re-interviewed after a mean of 22 to 37 years, they found recovery rates between 12 and 55%. Again, a cross-sectional study for them. Even at that point, they measured it. So not so different than ours, some higher, some lower. Younger populations, where they did look longitudinally, the rates came out almost identical to ours, about 13.5% over 2 or more years. So there was a wide range. And again, it illustrates and highlights the problem with that there are not consistencies in follow-up time, definitions of outcome, things like that, criteria for schizophrenia even. So full recovery, persistent recovery is rare in schizophrenia, but not unheard of. However, as I will show you in a second, there are opportunities to increase those numbers. So here's what we found. We developed a 5-tier taxonomy of clinical recovery in older adults with schizophrenia. And I'm going to highlight what we found. Stable state. Indeed, this is one of the stable states you might see in later life. So it wasn't the one they showed in that slide I originally showed you, because these are the people who are in persistent recovery. There's 12%, as I said, who seem to be in persistent recovery. These are people, again, if you use a personalized approach, you might maintain their current treatment or even consider reducing their medications. Perhaps they no longer need to be on medication. Then there's another 23% who fluctuate between clinical recovery and non-recovery. At some points in time, they're in recovery, and other points they're not. Now, these people seem to be an ideal group to where intervention can really move them perhaps along to full clinical recovery. or persistent clinical recovery. So that would certainly be a group to try to intervene at a high level. Now there's 11%. This is another stable state, but these are people who may show persistent clinical remission, but they never become community integrated. There's about 6% of people. And there are those who have persistent community integration, but didn't attain clinical remission, not at one point in time. So these people might benefit from a more targeted approach. We might not focus so much on their psychosocial, but we might focus on maybe changing their medications if they're community, if they're not in clinical remission, for example. On the other hand, if they're in clinical remission, but they haven't attained community integration, we might focus on measures to improve social skills or other psychosocial approaches. Now, 38%, the largest group, is a fluctuating state. These people are here and there, one point in time, they can attain clinical remission or community integration, but only at one point in time. So we need to move them up on a trajectory where they might be persistent, either in clinical remission or community integration, perhaps moving to that first, and then ultimately moving them where they could be persistently in those categories for at both points in time, over time. Finally, there's another stable state, and this reminds me of what you see on these charts that I showed you in the beginning, that with people who never attained clinical remission or community integration at any point in time, they might not even be considered recovering, and even to call them recovery in recovery might be a bit disingenuous, but clearly they would require a different type of intervention, both a very intensive approach to community integration and clinical recovery, clinical remission rather. And it certainly would require, I think, sitting down and saying, we're doing something wrong here because this person's not getting better on anything. And they're sort of an outlier because they're only 1/5 of the group. So I'm going to summarize my points here and take some questions. Again, so what we see here is outcome changes historically because of evolving diagnostic criteria for outcome, social factors. There are things we have hospitals that people used to be in institutions, then they're deinstitutionalized. We put more money aside for mental health. All these things are important. It's also important, as I said, to look at things longitudinally rather than cross-sectionally. Comprehensive view of outcome should include symptoms, functionality, combination of these, as well as positive health. And again, this applies to medicine in general. Outcome criteria are largely independent of each other. And this seems to be so in schizophrenia, but I think it's true in medicine to some extent also. And it would be useful, I think, when you're looking at medical illnesses to think about that. Outcome is not quiescent in later life, but continues to evolve. So schizophrenia is an area we can work in, and more people should be involved with will be for various demographic imperatives, but I think they should have a sense that there's something to work with and not that flat line at the end. It always reminds me of flat lining, like you're dead, and it's not what we should think of as schizophrenia. Again, we should think about a personalized approach. There are heterogeneous outcomes. I showed you there are various combinations, hundreds of potential combinations of various outcome measures. And recovery itself is a 5-tier taxonomy with varying degrees of recovery that provide guidance for treatment. So those of you interested, we did some articles on this. One is in the American Journal of Geriatric Psychiatry that came out last year, and another one came out last year in the clinics of geriatric medicine, and they should be available. We also have a book on this that came out in 2019 on schizophrenia and psychosis in later life, which touches on some of these and other topics and about the disorder. So